Clairmont, is a registered dietitian, and she was trained at Bastyr University and is now part of the comprehensive pain program, focusing on nutrition and how to manage pain with that. And she also works with our community health teams and a lot of our own primary care patients. Remember not to eat your snack yet, so there'll be a moment for that in a little bit. But I want to make sure they have all the time they need to do their presentation, so let's go ahead and give them a round of applause. Thank you for coming.
Okay, can you hear me through the microphone with this? All right. So yes, please hold off on eating your snacks. And welcome to our conversation, our discussion on nutrition as a foundational approach to integrative chronic pain management. So as Whitney said, my name is Emily Clairmont. I'm a clinical dietitian with the hospital. I work in a few different areas within the hospital. So I work for the comprehensive pain program. I work for community health team, and then I also work with our culinary medicine department. And I would say it was through culinary medicine that really brought me to the comprehensive pain program. And it was this initiative that we're working on to help individuals, patients, our community maybe refine this relationship or connection that they have with food and eating, and as well as how to prepare healthy meals. And John, if you want to.
Yeah, and I'm John Porter, and I am a physician. And I have been working with the Comprehensive Pain Program for the last 14 or 15 months, and I came on as the only individual working on it, and over that time have assembled a team of wonderful colleagues like Emily, with the intention of trying to figure out how we can work with folks who are experiencing chronic pain in a way that is patient-centered, that is empowering, and that brings them to a place of better comfort and function in their lives. And so this has been a journey. Emily is a wonderful colleague in this work, and we really have put nutrition kind of centrally in the program for reasons that we'll talk about as we go through the presentation. So wordy slides aren't good, but I want to draw your attention to the first bullet point and the last bullet point here, because this really forms the framing of how we're approaching chronic pain. And so we all know, well, let me just ask the group, how many in here have taken care of folks with pain as a primary presenting problem for, wow, that's about 99%. All right, let's use a 0 to 10 scale. On a 0 to 10 scale, from I find this really challenging to 10, I'm in ecstasy when I'm working with folks in chronic pain. Where are you on that scale? I see, yeah, hold up your fingers. I see a couple zeros, I see a 10 and a 6. Good. And let me ask another question. On that 0 to 10 scale, how do you think your patients experience their setting in your office? From 0 to 10, this is, I feel a little bit other, to 10, I feel right at home here in a medical setting. Some 2s, some 5s. Right. And so the key here is that we have been in a place for the last 20 years where we have been working with pain, in quotes. And pain's an interesting word, right? Because it implies that there's, kind of from a medical standpoint, that we can actually take it away. And that's true for an appendix. It's true for a strep throat. But it's the opposite of true for somebody who's experiencing a long-term problem related to fibromyalgia, osteoarthritis, a variety of medical conditions that we're all familiar with. So the question is, if we've been doing this and it hasn't worked, how do we take a different approach? How do we really try to institute a system that does two things? One, that frames pain as really suffering. Suffering is a much broader term. it really describes, in my experience, more accurately what folks who are dealing with chronic pain experience, because the pain has now assumed a life of its own. It affects them in their vocational realm, affects them in their family relationships, affects them socially. It's often very isolating. And so trying to look at pain, moving from that concept of just pain to really suffering, puts us in a different mindset about how we're going to approach it. And that's really the basis for the comprehensive pain program. The last bullet is also important to me, because when you're working, and you know this firsthand, when you're working with folks who are suffering, it's pretty heavy. It's a heavy pull or heavy lift sometimes. And so how do we design a system that actually is designed intentionally to keep your primary therapeutic agents, which are your people working with these folks, sharp and healthy and resilient and robust? And so that's kind of what we're trying to do, and I'll turn it over to Emily again here.
And really, the development of these intentions was something that our team worked on for weeks. But coming up with different variations and different ideas from each modality to say, how could we best work together to help individuals achieve optimal health, and whatever that might mean to them. And so, as a dietitian on this team, I try and take the intentions of the group and apply them to the nutrition practice, whether it be for group or whether it be for individual one-on-one. And so I can take, I've taken all of these intentions and I've applied them to what I do with patients and with participants, which is that when an individual has the space and capacity and opportunity to increase their knowledge of food or eating behaviors, then they have the opportunity to increase their awareness of their individual practices, and perhaps how maybe their eating behavior and how they interact with others with regards to food and eating, their health. And then that hopefully would result in change. Change, again, of their eating habits, their food choices, their relationship with food and eating, perhaps even that relationship with their pain. So one of the things that is really fantastic about our team is how we all do work together to come to a mutual kind of agreement, and this was an example of one of those. And so these are again just another example, I would say, of how we share our intentions throughout the comprehensive pain program. With kind of medicine and psychology, and you'll see this in the next slide as well, but with medicine and psychology having a large presence in what comprehensive pain program participants, it's a mouthful, what they experience when they come to CPP, nutrition also has a large component, which is again to provide individuals with this experience of how food and eating can help change their experience with life.
Good. Yeah, and the approach is really intended to be transdisciplinary, which gets thrown around a lot. But between all of the disciplines that are represented, both traditional and integrative, on the team, the intention and the goal, and I think what we're really finding, is that we actually get better answers when everybody is looking at the same person and coming at it from their discipline. So a core piece of the approach here is an interdisciplinary case review for everybody who comes into the program. And that's 10 or 12 people sitting around the table, anesthesiology, acupuncture, massage, nutrition, kind of reviewing the case and giving their best input about what the participant might benefit from. And this is another really busy slide, which would take you 20 minutes to read, but I want to just summarize what the program is. And a couple things. It is based on group approach. intentionally, right? So these folks come into the program often in a pretty isolated state, and so all of this work, all that's represented here, is related to folks going through a group. There are two so-called levels, and here's again where the language is. We've been calling them tiers, Tier 1 and Tier 2. Tier 1 would be for the folks who really might have been previously in Dr. Naylor's mind-body approach. These are folks who are reasonably functional, maybe working, maybe on relatively low MMEs, and kind of are kind of struggling with pain, but maybe have some outlets that they find rewarding in their life, even with that. The so-called Tier 2 folks are folks who may be more entrenched in their pain, may have had to change their vocational identity or stopped working, may have experienced changes in their family relationships, social relationships, tend to be on higher MMEs. So back to the language for a minute. We have cooking classes, and if you put people from different tiers into the same room with Emily and Leah, and they pretty soon start asking, what's a tier, right? And why am I Tier 1 and Tier 2? And it harkens back to my question of, am I in the highest reading group or not the highest reading group in my 4th grade class, right? So, so the language, again, is important. We refer to the folks going to the program as participants, and the tiers now, as everything evolves in the process, are communities. There's Community 1, Community 2. The core of each community experience for the Tier 1 folks is what we call a Compass program. It's a once a week for 8 weeks group session with Dr. Heather Finley, who is our psychologist, and that's based on acceptance commitment therapy, and that's designed to provide folks with some strategies to work with their situation. Tier 2 has the Compass program, but also what we call the PATH program, and that adds an integrated medical visit. Tier 1, the Compass program is a 90-minute, it's a 90-minute offering. The integrated group medical visit is a 2-hour offering, and that includes a chance to talk with a medical clinician. It includes a significant amount of mindfulness. It includes a didactic offering, an educational offering about what's happening in pain. Could be medications, could be the sensitized CNS, and then some experiential session, which might be movement, might be yoga, might be art. So those are the cores. This is a lot to explain in one slide. Around each of those, then, folks have access to the modalities, to the integrative therapies, right, which are listed here. And so this is 8 weeks, right? This is for folks who have been suffering for a long time. So what in the world are you trying to do, right? And the goal truly is this. It's to give folks a time to come into a place where they can say, here I am in my life. How do I move forward, right? It takes us out of the routine of the 15-minute visit in the primary care office. It gives them a chance to kind of reset and understand that really, if I'm going to be able to move forward, I have to be involved in this. I have to take on some of this work, and it gives them some strategies to do that with. And so the expectation is that folks will leave back to the medical home with some new knowledge, with a sense of heightened self kind of empowerment in the whole process. And so, Emily, do you have anything to add?
Yeah. And so just like what John is talking about, using the word, as it evolves, this program is definitely in its evolution. And so part of this, when I came on board, part of the conversation was to say, how are participants going to have access to nutrition, and what is that access to nutrition going to look like? What are nutrition offerings going to look like? And there were several conversations about how and what that was going to look like. And so one of the things that we talked about, as well as with Laurel, is helping to understand that nutrition is a foundational component of health. We have to eat. for sustenance. But we also have to, eat in certain ways, to develop our confidence in the kitchen, to develop that skill, both technical skill, but also there's a social component to it as well. So in this conversation, kind of the evolution of how nutrition would exist in the clinic, in the program that eventually came about to what we're doing now. And so, again, busy slide, but you will see that nutrition is sprinkled throughout the program and throughout the offerings in multiple places, and this is intentional to be able to give participants as much exposure to nutrition education and practice as possible. So there are group offerings. There's also individual offerings, and I'll go into that now.
Good.
Yeah.
Can I just say one or two more words about this?
Yeah.
The tier 2, the path part of this is really, that's the integrated group medical visit. That has a framing for folks that is based on mindfulness, and specifically mindfulness-based self-compassion, right? Because when you talk to folks who are in this situation, there's a tremendous amount of self-talk and self-experience that has to do with being hard on oneself. And so that's an intentional piece of this. The program being mindfulness-based, nutrition is, again, as Emily said, foundational in this, right? If we can get folks to focus on how they're approaching what they eat, we know it does good for them in terms of their condition, but it also sets the stage for them to think about how they're doing everything in their life. Movement, sleep, how they're approaching their day-to-day life. So, good.
And those, I think maybe more in the next slide, but why not talk about it now, is that's built into the curriculum. So, 1 week, week 1 builds on week 2, or the reverse of that. Either way, it's consecutive. That what individuals are learning throughout the program is intended to build on each other, and it is intended to help them in all areas of their life. So again, the individual, let's say the group offerings. So in PATH, which meets once weekly for 2 hours, I deliver a nutrition pearl. That's what we're calling it for now. But I pop in for 10 minutes or so with like 5 minutes of questions. And there's an education piece, there's a discussion piece, and it's intended to complement what the conversation is going on in the group prior to me walking in. Mm-hmm. Did you want to say?
I always have more to say. Thank you. The second session after the orientation is a culinary session put on by Leah and Emily. It's intentional. It's designed to give folks a time to get to know each other, to pick up some information. It is probably, we're only in the 4th week of our Tier 2, but across the program, it's the most popular offering. I want to just mention, along with what the participants are experiencing in the program, there's 2 other notable facts. One is that for people who are primary support providers for the participant, there are offerings 3 times during the 8-week session. All right, and the intention is that they find out what's happening with their loved one or the person they're helping with their chronic pain, and they also get to connect and have some support. And then at the end of the 8 weeks, there's an ongoing opportunity for folks to continue in alumni groups, which is primarily it's not a group medical visit, it's a group therapy process, and again a chance to for people to connect and kind of refresh whatever skills they need to refresh. Mm-hmm.
Yep. Yeah, and so week 2 in the program is is a culinary medicine experience for participants. And there are other opportunities for culinary medicine at CPP. And these classes are essentially modeled after a successful education series that culinary medicine does out in the community through HealthSource, our Food Matters classes. But these are hands-on 2-hour classes that participants can come to. They're free offerings, but they're intended to be fun. I mean, there's education sprinkled in there. There's both nutrition and culinary. But again, it's a new experience that individuals likely haven't had before that is specific to their current situation. So all classes are, the curriculum, it's built on the idea of an anti-inflammatory diet. I do think that that's, what that is likely going to evolve as the program evolves.
Yeah. And I think one piece of learning, aside from that participation in the curriculum, Emily and Leah offer cooking classes at CPP on a monthly basis. And one thing that you've learned is not to tell what you're going to be cooking.
Yes.
Because people will say, oh, I don't like fish, and not come. So, but that's really not the point. The point is to kind of go through the process and connect.
Yeah. But it was a great learning process, learning hurdle. I don't know if you want to call it that. But it was like, oh, yeah, no, maybe missing the point. The point is to expose yourself to, learning about healthy anti-inflammatory fats. And then when they get there, surprise, we're cooking fish. But we're learning this along the way. So again, we've kind of already mentioned this, but, how do the different curriculums, how do they develop in relationship to one another? So for every week, PATH has a defined curriculum. For every week, Compass Living has a defined curriculum. And I was able to look at those and then develop the nutrition curriculum based on that. So again, when I would walk into PATH, I wasn't walking in and just, oh, these are measuring cups, that I want it to be relatable. I want individuals to connect with whatever the nutrition education might be. And this is an example of week 3. So in PATH, large picture, PATH group is talking about the science of pain. Compass Living is talking about the cycle of suffering, and then I developed my curriculum to come in and talking about maintaining nutrition while on opioids. So essentially the drug-nutrient interaction piece of things, and we talked about food and symptom diaries. And again, we will see, maybe that was too much, maybe that was too little, but the idea is that they work in complement to one another.
Yeah, and that planning of the curriculum mirrors what happens in the care of the participant, so that everybody has input and hopefully the offering is synchronized.
Yeah. And so I think we've already talked about the nutrition connection a little bit, but it doesn't hurt to talk about it a little bit more. So we've already kind of mentioned, and I think we might know that nutrition, like we need food to eat and to live, but also nutrition affects multiple areas of our life. And again, the development of nutrition services in culinary medicine at Comprehensive Pain Program is taking into account all of these different aspects of one's life. And I think this would be a nice time to just provide you with some examples, some observations that we've already observed through the cooking classes that we have, as well as in PATH. So Leah and I, Leah, our chef educator, week 1, so we started offering cooking classes prior to the start of the program, and this was something that we could do. So we said, why not? Let's do this. These are participants that are perhaps waiting for an activity, for an offering. This was something, this was a curriculum that we had, so why not do it? So week 1, we have 4 people signed up, and we have 1 person show up for the cooking class. And we, Leah and I would like to say we're a pretty dynamic duo. In the kitchen, we have fun, and I think we have other tenets and goals that we're working towards in our class. But I know we also like to have a lot of fun. We like to laugh, because that's part of the experience of cooking and eating. It should be joyful. So anyway, I go to meet the patient out in the waiting room. I can tell she's shut down. She knows that she's the only person that showed up for the class. She was expecting a group experience. And I introduced myself and I said, hey, don't worry about it. Like, why don't you come on back? Like, Leah's in the kitchen. Like, we'll get things going. Maybe other people will show up. And she was, Leah can attest to this, not happy. Let's just say, no eye contact, it expressed, I'm in a lot of pain right now. I don't feel good. I was like, come on back. So we went back to the kitchen. Leah was in the kitchen. We were getting things going. We had it set up for a nice class. Our participant sat down, really not engaged with us, but we kept at it, kept to the conversation, started talking about, just having a conversation about food and what we were going to cook. As the class progressed, she stood up, which she told us she wasn't going to do. She stood up, she helped us prepare the vegetables or the foods that we were cooking that night. She shared the meal with us. She left shaking our hands. She was laughing, throwing jokes around just like we were. And she has come back to every single class. And we do need to, we actively need to figure out what we're going to do, because these classes, they are very popular, I think, from the standpoint of lifting people up. But another piece of that is that I heard from our psychiatrist, Mac Abernathy. He told me about a week later, he said this participant was an active or a frequent caller. She called multiple times during the week, and that he hadn't heard from her in 2 weeks. And so that was a real testament to the fact that she had a great time, that she enjoyed. And of course, we followed up with her. She's made the recipes a couple of times at home, but it was something different. It was something different for her to experience. It was a different way for her to interact with food, and self-care and self-compassion. And now she is in PATH, and I don't know if you have anything you'd like to add.
Well, yeah, she has just been a regular participant. It's a great story of how people in the group and in the culinary medicine segments kind of do come to life, that these connections form, which I think really are therapeutic for folks. People stay after and talk at both at PATH and the cooking classes. It also goes to the point of the fact that these are folks who are in the middle of their pain. And so, for example, in our first Community 2 level, we've lost several folks. One has been induced onto Suboxone and hasn't been there for a while. One is having ECT therapy, which started since he started the class. Another has a recent ostomy, which they feel self-conscious in the group. So again, to the extent that we can engage people and involve them and motivate them to come back, that's what we want, and that's actually what the cooking does. Mm-hmm. Yeah.
And so one of the other, going back to evolution and talking about the development of nutrition services, a comprehensive pain program, it's really, it's quite a larger picture than that. It's the development of medical nutrition therapy for chronic pain, which I can tell there's no chapter in any of my textbooks on nutrition for chronic pain. There is a lot out there in terms of an anti-inflammatory diet and different constituents of the anti-inflammatory diet, which are, up here, balanced nutrition, consistent meal times, high fiber, lean protein, anti-inflammatory fats. We talk a lot about phytonutrients and their role in reducing inflammation. but there is a natural evolution to the medical nutrition therapy for chronic pain patients. And this is something that excites me quite a bit because I'm learning things of how our participants feel. And that perhaps, it's not necessarily just about, reducing, inflammatory compounds. In week 2, one of the first things that came up is that 3 out of the 5 of our participants are also, have significant GI symptoms, which was not, maybe not a surprise to me, given the medications that they're on. But that does inform me to say that the medical nutrition therapy that I create and provide does need to take that into account. So thinking of those drug-nutrient interactions and how, it is likely not going to be a basic anti-inflammatory diet conversation, and that's where the individual consults really come into play, where participants can talk to me about their specific concerns outside of, say, just like the anti-inflammatory recommendations.
Yeah. And I think another thing that we're experiencing is, and is intentional, is for other folks to have input. So I think in the last class, the occupational therapist sat in. Yeah. The participants, a couple of them were saying, I can't even stand at the table to chop, right? And so the kind of barriers to even participating in preparing your food and then eating something you find enjoyable are there. And what kind of practical, pragmatic approaches can we suggest to folks to work with that?
And to add that the group dynamic is awesome because it allows participants to have a voice. It's not just, a group could be John or myself just talking but we learned right off the bat that people want to talk to one another. Mm-hmm. People want to share what they've been doing, what works, what doesn't work, and it's awesome. It's fascinating too to bring up a topic, positive affirmation in terms of that's what I was talking about last week with the group a little bit. Positive affirmation in terms of helping remind yourself of why you're trying to make changes to your diet or why you're trying to make changes to your eating behavior. And we have a participant who does he likes to use his voice all the time. And he was able to speak to positive affirmation to the rest of the group. And I'm sure that lands differently. I'm sure it lands positively to his peers. Mm-hmm.
Good.
Yeah. So this is this is a handout that's out front, but just an example of a tool that participants can walk away with. So again, there's the didactic portion, there's the experiential portion, which we'll talk about in a little bit. There's the hands-on portion, but all the while, it's really nice for people to walk away with a tool. And so this is a version of My Plate. If you're familiar with that, quarter plate protein, quarter plate starch, or whole grain, half the plate vegetables. And this was intended and developed to bring in and call out known anti-inflammatory foods. So whether it's for their phytonutrient content or whether it's for their fiber content or polyunsaturated fat content, that those particular foods are called out so that when they get home, they can put this on their fridge or they can put it on their cabinets or keep it in their binders at home, to be able to think about when they're building a meal, is it balanced? Because that's a huge piece. I mean, that's like foundational nutrition, is can we get individuals to just put together a balanced meal and eat consistently throughout the day? And then all the while, maybe choosing from some of these foods on this list to, question.
the salubrious contents of these nutrients in frozen fruits and vegetables?
Good question. I don't know any specific call out or research that was looking at that. However, what I do tend to educate participants on. And I should repeat the question.
Mm-hmm. Yeah.
And the question was asking about, whether or not the nutrient content of the foods recommended are maintained in frozen state. And so what I tend to educate participants on is if that is what they have access to, that is most certainly going to be more beneficial than not having it at all. Yeah.
And I think Erin also raises the issue of barrier in terms of financial means to acquire this, which is an issue for many of these folks. Many of them don't have money for gas to get to the office sometimes. So that's something we're working on to try to find some funding for, to make sure we're surveying everybody and then providing connections to community resources and food boxes for those who have emergency needs. So it's a real issue.
Yep. Yeah, another question.
Yeah, and I didn't, Kim's asking about the social determinants of health and are those determined at the beginning of the program, and in short they are. The intake process has twofold. Laurel Audi pre-screens folks and kind of gets a sense of their social situation and what group they might fit best into, and then the intake actually is done by the psychologist and one of the medical clinicians, and so the goal is to have a good sense of an individual story with regard to those determinants. Yeah.
Yes, and so and all participants in that intake process are given the 2-question hunger vital scale. And so we do know going into the program whether or not they self-define as food insecure. And so I'm also just being mindful of time. But our nutrition experiential is just another, example of how nutrition is incorporated in the program at CPP. And so our experientials, different than the hands-on cooking class, but the experientials include, product identification, perhaps tasting. And these are incorporated into PATH throughout the 8-week program. And so it gives, it tosses it up a little bit, so it's not just a nutrition didactic, but that there's also an experiential. So in that, I was just talking with somebody this weekend about, the impact of aroma, for example, or taste, that has on our memory. And so it's one other way to link an individual to perhaps a growth experience or a positive experience that they're having at the clinic.
Yeah, good. And an example of the experiential might be the Nourish Bowl that you and Leah helped with last time. So went through the Healthy Plate, and then Leah had laid out an array of just beautiful vegetables and proteins, a little bit of fat. And then went through one by one with each individual to kind of pick out what they wanted and some things they had never seen or even heard of in some cases. So, yeah.
Yeah. And so, in kind of lining these up, I believe these are the weeks of PATH where there are experientials, where we've built in experientials. And so, the notion of self-advocacy, again, with the overarching, self-compassion, that choosing healthy foods for yourself can be worked into the language of that session. Okay, and so now we can have a snack. And this is, I intentionally chose these pictures because this is oftentimes what this is what it looks like when we have food in front of us. We see the food, we get super excited for it, and usually it stops. It stops there, and then we snarf it, or devour it however we can. But what we're going to experience today is just a practice of mindful eating, and it's intended to kind of break after that Boston Terrier. It's like we can get excited about food, but we still have to take a pause, take a moment to enjoy it. And that's from the standpoint of just not giving ourselves heartburn or indigestion, but also from the standpoint of setting our body up, for digesting nutrients. So did everybody who wanted one get a bar out front? You got one. Okay, and so in these bars, these were developed through culinary medicine for our community series for Food Matters. So it has, you'll notice, if you were to look at it, which that's going to be part of this, it has a lot of the components that we might see on that wheel for a balanced snack. So, mindful eating. Have you guys practiced mindful eating? Okay, a little bit. Well, here we go. So mindful eating, so take a seat in your chair, and this is the same. If you are at home, maybe find a seat at the kitchen table, find a seat, on the couch, get comfortable, and then take a look at the food. Take a look at the colors, take a look at the texture, maybe identify some of the foods. Is it shiny? Is it dull? And then when you're ready, take it up to your nose, smell. Does anything kind of call out? Or does it just smell like a snack? And stopping there, are you guys noticing anything that's happening in your mouth? Starting to salivate a little? Maybe your tummy's starting to talk to you, saying, I'm ready. And I always kind of say this, it's kind of cool if you notice that your mouth is salivating. Your body is setting up to digest. This is the first stage of digestion. Chewing, mastication, as well as amylase, that first step in carbohydrate metabolism. So when you're ready, take a bite, chew 3 times, wait, see what happens. If it's 5 times, that's cool. Is your mouth salivating even more? What's your tongue doing? And when you're ready, swallow. This is also, it's a very fiber-rich bar. It might need a few extra chews. And then before you take your next bite, and I notice there's still a lot of chewing going on, but just give a moment to reflect. Take a moment to what's going on with your stomach. Do you feel the bolus of food going down your esophagus? Are you ready for more? Because that's another thing, right? Normally we've got the next bite prepped and maybe even in our mouth before we've finished our first bite. And so again, from that standpoint of compassion, self-compassion, from that standpoint of providing yourself with the time to digest and absorb appropriately, mindful eating is certainly a very helpful tool. And yes, you might need a sip of water to help this down, or tea. All right. And this is something that we do. Leah and I, as well as the other members of the culinary medicine team, we incorporate mindful eating into every activity, every class that we do, because it is vital that if we're going to take the time to prepare a meal, if we're going to take the time to eat regardless of what it is, it's very important that we provide ourselves with the space and opportunity to digest it appropriately.
I can just guarantee you from personal experience that in addition to being delicious, that bar will last you 2 full days. 2 days you don't have to eat if you eat the whole thing. Congratulations.
Yeah, you have snacks for 2 days. Okay, and so kind of, wrapping up here, these two kind of bundles of words are observations that we have within our clinic, within participants, as well as on our team.
Yeah, and I would just highlight that truly in the group experience for participants, that experience working with peers is powerful. It's really what we rely on to kind of help people gain agency and gain connection. And so when the groups are carried out in the PATH session, a lot of time is left for group experience. The desire is to not be standing there or sitting there telling people what to do or what not to do, but to call on them to kind of start to use their voice to figure out how they're going to gain agency, gain efficacy, master their current situation.
Yeah, and this ties right into the teamwork that we have. And so this is a snapshot of what our case review, what our team meetings look like. As you can see, there's so many smiles around the table.
Looks like song is about to break out, but
yeah.
But again, the parallel to what we want for those folks who are coming through the program is this sense of really joy, right, and connection, and the wisdom and the sense of connection that comes from being part of this group, right? And so there's that parallel process going on for participants and for the folks who are working all together as colleagues. It looks like I'm about to leave there, but I don't think I am.
No,
yeah.
no, I don't think you were.
Good.
Well, yeah, I think that's it. So thank you so much for coming this morning on Daylight Savings.
Yeah. Good.
Daylight Savings Monday. Any questions?
Yes.
Yeah.
What do you do if I love goat meat, mango, and mangosteen pies?
Okay. So what's the question? What would I tell you? Well, I would say in the context of what? Because I see. They're not on the list. I got you. Yes. And so that's the individual level, right? And so a tool can help somebody perhaps understand where their foods might fit into that model. And so, yes, so I talk with individuals all the time that, refugees from, Africa or Iraq, and that's part of my job, is to try and figure out how I can take those foods that are native to their culture and fit them into the same model. And I find a lot of joy in that. And there's actually there isn't, the foods for chronic pain, but that message exists in so many different languages. The Harvard Healthy Plate, for example, exists in 50 different languages. And I love using that because it's such a, I'm not going to talk to somebody who doesn't eat these foods and say, eat these foods. That it's a really valuable connection to be able to make with somebody when you can say, I understand what yucca root is, and I understand where that fits on the plate model.
Yeah.
Okay, great.
And a lot of the work actually with these folks and the work that Emily does and Leah does and everybody at the table is doing is really establishing connection, establishing rapport, understanding where that individual is and working with that. So it's not a prescriptive approach or a proscriptive approach.
It's a discussion. And, and speaking of, culture, for our participants, convenience, convenience package, which may not be that different, maybe from a lot of our patients in other practices, but they are not in the practice of cooking food at home. And so we do have to, Leah and I talk a lot about using gateway foods, gateway versions of different foods to help just introduce them, give them the exposure. Yeah. Any other questions?
Laura. Yeah. Yeah, I can. The question is, can you describe the acceptance commitment therapy? And essentially, it's related to cognitive behavioral therapy, but it is based on, in the work that Heather does with it, establishing, here you are, what are your foundational values, where you are, and then how do you work to kind of achieve them or move towards them. And so it is using the individual's own framework of what's important to them, accepting that they are here, and then moving forward in this condition. So,
value-based.
Value-based, yeah. What are your values? How do you act on those values? How's that going, acting on your values, right? Because when people really stop to think about what's important to them, it could be, my family is important to me, and I want to get on the ground with my grandchild and play, and so that's a strong value, that connection. And so in what ways is the way you're approaching life now making that difficult? How can we pragmatically help you kind of figure out some ways to do that? And that might happen in that group. Occupational therapy might be involved. Every one of the disciplines might end up being involved.
I would add to that the notion of value-based is what is discussed at our case reviews. So when we review an intake, one of the questions that is asked, what are the goals? And a lot of times, the goal is not, related to pain. It's related to a value like wanting to, participate more with their family. And so we take that into account, each of the disciplines, we take that into account when we're thinking of that recommendation, whether or not nutrition or acupuncture or Reiki is appropriate for this person based on what they want to achieve.
Laurel, did you have it? Yeah. 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 And just for folks not on site, that comment was, Laurel was saying, sometimes the discussion is, what if we can't get you there? Then how are we going to work with that? Where else do you want to go?
Two things. So one is, answer Dr. Ryder's question. This is from the Journal of the Science of Food and Agriculture. The frozen and fresh foods have equal nutritional value.
Good.
And in some cases, more nutritional value than frozen foods.
Yeah. Yeah, right, and that's, yeah.
And then a second question. So this is sort of a two-part question. One is, how do we, if we have patients that we think are appropriate, how do we get them into the program?
Yeah.
If we have patients that we think might benefit, but are closed off to the idea that anything other than this is going to be what helps them.
Mm-hmm.
What experience do you have in sort of moving them?
Yeah. So for those off-site, newsflash that the frozen foods turn out to be doing well in terms of nutritional value. For folks who are interested in referring individuals to the program, that was another question. So part of the challenge here has been how to fund this, right? Because if you do a fee-for-service traditional RVU approach, the co-pays become prohibitive and many of the services aren't covered. And so the issue has been funding this. We now are working on two streams. Blue Cross Blue Shield has agreed to a bundled system for this 8-week process, which allows access for everything, a copay, which is going to be fairly small, we hope, for each month participation. So we have now a file from Blue Cross Blue Shield for folks in your practice who fit a set of criteria. We don't know yet how well they match with your experience of the individual, but as we finalize that funding from Blue Cross Blue Shield, we'll be in touch with you about these folks are covered for these services. Which of them do you think ought to be coming to us? And so that's actually a hopeful development. On the Medicaid side, we put a proposal into DEVA last fall and have had good feedback about them funding that. We think that may happen in June because that population tends to be folks who would really benefit from this. And then the other question is, what about folks who aren't interested in changing their medication approach, which is still many of the folks that we've inherited in the program. And the encouragement then is to, we're happy to see them, do an evaluation, talk with them about some of the work that's going on there. And that I'm always making deals with individuals. If we do this for a while longer, here's the deal. I'd like you to try, some of the services that are offered here and see how that goes for you. So everything's in a negotiation, right? But trying to get them into the place, we're happy to see them, talk to them about what's happening, the experiences that people are having. So, good.
I don't know if it's deliberate. This photo is great. It's very Da Vinci Last Supper.
Yes.
Over the head in the center, and
Yeah.
people on either side.
I know. I know, it's creepy. I agree. So, yes, Dr. King.
I've noticed back in the day when people were going through Dr. Miller's program, that they got a great introduction, which I suspect would have been a great introduction and some great fundamentals. But when it comes to things like mindfulness,
Right.
ongoing investment over months to years, continue to bear fruit.
Right.
And I also know from other research on group-related activities in healthcare that groups don't want to break up.
All right.
Stay together. Has there been any thought yet on how to somehow keep part of this going?
So, yeah, and that would have to do with the alumni track, right? So after that 8-week, and we're really concerned about this actually, not having people drop off the edge of the table and find themselves lost again, and how do we keep that connection? So that alumni track in the bundle goes on for 6 months. Those are monthly meetings. Again, we're going to have to adjust that to figure out what really works best for people, how to keep them connected. But the other challenge going back to the medical home is, okay, I did great with massage therapy. I'm having a flare, I'd like to go back and do that. Well, guess what? It's not covered for you, right? And so Kara Feldman Hunt has worked on a registry of folks we feel good about in each of the disciplines that we're talking about. That funding issue for people once they leave the bundle isn't yet worked out. So that's a challenge we have to face, yeah. Good. Well, thank you very much for coming. Have a good week.
All right. Nice job.
Nicely done, Emily Clairmont.